Bismillah ar-Rahman ar-Rahim. Today is Friday, so don't forget Surah Al-Kahf. أعوذ بالله من الشيطان الرجيم. الحمد لله الذي أنزل على عبده الكتاب ولم يجعل له عوجا قيما لينذر بأسا شديدا من لدنه. بسم الله الرحمن الرحيم. So, what to expect in scleroderma or systemic sclerosis cases in FRCR? What to expect to see and how to comment. So this is the first case here. This is actually an FRCR case. This is a chest X-ray of a patient with difficulty swallowing. So I need you to look carefully here. Can you see this radiocardiac opacity? It's also seen here. It's the same. It's typical, the same. And this, can you see this opacity? This is typical appearance of distended esophagus. Typical appearance of distended esophagus. As you can see, the opacity is continuous with the abdomen. It's typical appearance of distended esophagus or achalasia of cardia. Okay, this is the same case. Sorry, it's not the same case, but this is the same disease, which is the distended esophagus or achalasia of cardia in a different patient. On CT scan, you are expected to see the esophagus is dilated like this. This is the trachea, this is the esophagus. This is the esophagus here. This is the tracheal bifurcation. This is the esophagus, is dilated with air fluid level. Air fluid level here. This is the esophagus. This is the aorta and the IVC. This is the esophagus. This is the azygous vein. This is the dilated esophagus. Here, can you see this too? This is the dilated esophagus. So all of these are examples of distended esophagus or achalasia of cardia due to esophageal fibrosis in systemic sclerosis or scleroderma. Okay, so let's see the other case. Another patient with chest symptoms. Okay, this is the chest X-ray. As you can see here, there is reticular and nodular. Reticular and nodular opacities. Okay, more with basal, more in the basal parts of both lungs. But you need to comment here that the lungs are still hyperinflated. Although there is reticular opacities, the lungs are still hyperinflated with no volume loss. This is very important to differentiate between the non-specific interstitial fibrosis and the idiopathic pulmonary fibrosis. Because if this lung is an example of idiopathic pulmonary fibrosis, it won't be like this. The reticular opacities will cause significant decrease in the lung volume, significant volume loss. Okay, so the presence of the opacities in a hyperinflated lungs with no volume loss is characteristic of non-specific, is more likely to be non-specific interstitial pneumonia. What is the non-specific interstitial pneumonia? Opacities in the lungs with underlying cause, with an underlying cause. Okay, so here hyperinflated lung with opacities equal non-specific interstitial pneumonia. Okay, let's look for the underlying cause. What is the underlying cause of non-specific interstitial pneumonia? Connective tissue disease. Okay, let's look for any kind of connective tissue disease. There is no clavicular erosion of rheumatoid arthritis. There is no cardiomegaly to suspect the drug-induced or amiodarone-induced lung fibrosis. There is no retrocardiac opacities, which I showed you, which I've showed you above. There is no retrocardiac opacities to suspect scleroderma. There is no calcified pleural plaques to suspect asbestosis. To suspect asbestosis. There is no, but not here. On CT, it will be better. There is no hyperdense liver to suspect amiodarone-induced lung fibrosis. So, after suspecting non-specific interstitial pneumonia, you need to suspect the cause, the underlying cause. Okay, as I mentioned here. You will say like this: given the history of several months of shortness of breath, the most likely diagnosis is non-specific interstitial pneumonia, as there are opacities with underlying cause or connective tissue disease. The differential diagnosis is idiopathic pulmonary fibrosis. This is a differential diagnosis. What is the idiopathic pulmonary fibrosis? You will see evidence of significant fibrosis of idiopathic cause. There is no cause of idiopathic cause. It won't be associated with connective tissue disease as the underlying cause. So, how to manage? If this is the first presentation, I would recommend high resolution CT scan, a high resolution CT scan for further assessment and a chest consultation. Okay. So, in scleroderma, you've got two cases. Either a case in the early disease or a case in the late disease. This is a case of scleroderma in the early disease with non-specific interstitial pneumonia. Only opacities with no significant volume loss. Look at this case. This is also a case of scleroderma in the early disease. Only opacities, but with no significant volume loss. This case, a case of late disease of scleroderma. There's significant fibrosis, as you can see here. Significant fibrosis. So this is a late case of the disease. Okay. So let's talk about this case. Is considered early disease too. No evidence of significant fibrosis. Okay, let's comment. So in the scleroderma of the lung, in a case with scleroderma of the lung, you need to look for four important findings. The first one, evidence of ground glass opacification. Here is the evidence of ground glass opacification. Okay, evidence of reticular opacities. Can you see this white lines? This is the reticular opacities. Usually, the reticular opacities will cause interstitial septal thickening. Okay, reticular opacities with interstitial septal thickening. Okay, So the second feature is reticular opacities. Okay, reticular opacities, as you can see, interstitial septal thickening. Okay, and the third one is traction bronchiectasis. Traction bronchiectasis, as you can see here, here. This is the traction bronchiectasis. Okay, the last feature you need to look for is significant degree of fibrosis. Significant degree of fibrosis. What are the features of significant degree of fibrosis? Honeycombing, pleural fissural thickening. There is no evidence here of honeycombing or pleural or fissural thickening. Okay, so the case here doesn't show significant degree of fibrosis, only shows a peripheral rim of ground glass opacification, a peripheral rim of ground glass opacification. Can you see this sparing of the subpleural area? The ground glass opacification with subpleural sparing. This is a characteristic feature of non-specific interstitial pneumonia. Ground glass opacification with subpleural sparing. Okay. Also, the opacifications, either it is the ground glass or the reticular opacities, will show a kind of gradient, showing a gradient. It's called epicobasal gradient, kind of epicobasal gradient with a sparing of the apices and the increasing involvement of the bases. Sparing of the apices and the increasing involvement of the bases. This is also a characteristic feature of the opacities in non-specific interstitial pneumonia and idiopathic pulmonary fibrosis. Also, there are reticular opacities with interstitial septal thickening seen in the same distribution as I mentioned. All the opacities seen in the same distribution and with the same gradient, seen in the same distribution with basal, with the same gradient, which is basal predominance. As I mentioned, there is also traction bronchiectasis, more in the basis. There is no honeycombing, pleural, or fissural thickening. There is no significant degree of fibrosis. Okay, the lung findings are characteristic of non-specific interstitial pneumonia. Non-specific interstitial pneumonia. Why? Because we've got only opacities with no significant degree of fibrosis, with underlying cause. This case has evidence of connective tissue disease in the history. No clavicular erosion. Also, you need to search for the underlying cause. No evidence of rheumatoid arthritis, as there is no evidence of clavicular erosion. No evidence of cardiomegaly or hyperdense liver to suspect amiodarone or drug-induced lung fibrosis. No evidence of dilated esophagus. No dilated esophagus here to suggest scleroderma, and no calcified pleural plaques to suggest asbestosis. Okay, this is a full comment of this high-resolution CT scan. Okay, what about this case? This high-resolution CT scan showing there are prominent Reticular opacity. So what are the 4 features you need to look for? Reticular opacities. Can you see the reticular opacities? Yes, it's very prominent here. There are prominent reticular opacities with septal thickening. Can you see the septal thickening? Everywhere there's septal thickening. With ground glass opacification. Inside these reticular opacities, you will feel that there is a kind of ground glass opacification. The ground glass opacification is a kind of more brighter than the normal lung. This is the normal lung. This is the more brighter, more grayish lung. This is, you can say it is, this one is dark gray, this one is brighter, more brighter than this normally seen lung. So there's evidence, yes, there's evidence of ground glass opacification. Okay, in a peripheral subpleural distribution. Here, the ground glass opacification doesn't show a subpleural sparing. Okay, because the disease here is more extensive. Okay, so the ground glass opacification here doesn't show the subpleural sparing. Okay, on the opposite side, this shows subpleural distribution, not sparing subpleural. This is its main area, subpleural distribution. Okay, with more peripheral and basal. It's seen more basal and peripheral. Okay, let's see the next one. The next finding is traction bronchiectasis. The next one is traction bronchiectasis. There is evidence of traction bronchiectasis, as you can see here. Peripheral bilateral traction bronchiectasis. Okay, the last finding you need to look for is significant. Okay, sorry. The next finding you need to look for is significant degree of fibrosis. Significant degree of fibrosis. Okay, as you can see here, there is evidence of cyst formation. This is the evidence of cyst formation of early honeycombing, indicating early honeycombing. Okay, there is also pleural thickening and fissural thickening. This is the fissural thickening and pleural thickening. Can you see the pleural thickening here? This is a sign of significant degree of fibrosis. Pleural and fissural thickening. So there are signs of significant degree of fibrosis in this case. The lung findings are characteristic of usual interstitial pneumonia. It's not non-specific interstitial pneumonia. It's now usual interstitial pneumonia, because there are evidence of significant degree of fibrosis with underlying cause. Which is the connective tissue disease. Let's search for the other connective tissue diseases. No evidence of clavicular erosion to suspect rheumatoid arthritis. No evidence of cardiomegaly or hyperdense liver to suggest drug-induced lung fibrosis. No evidence of dilated esophagus to suggest scleroderma. No calcified pleural plaques to suggest asbestosis. This is a perfect comment on a scleroderma case. Okay. What about the musculoskeletal system in scleroderma? There is resorption. Okay. You need to comment on, or you need to look for three findings in a case of scleroderma, musculoskeletal, in a case of a musculoskeletal scleroderma. Okay, so the first thing is soft tissue calcinosis. Soft tissue calcinosis. This is the first feature. There is no soft tissue calcinosis here, but here you can see soft tissue calcinosis. There is globular, periarticular, soft tissue calcinosis. Globular, periarticular, soft tissue calcinosis involving the third and fifth fingers. Okay, so you need to imagine that scleroderma is affecting the musculoskeletal system from superficial to deep. From the skin, it will cause soft tissue calcinosis. Then the joint, it will cause a degree of arthropathy, diffuse. It will be diffuse arthropathy. Then the bone, it will cause erosions of the bone, erosive arthropathy, erosions of the bones. Okay, so the first thing is soft tissue calcinosis. Seen here, not seen on the previous case. Okay. What to look for? Resorption of the tufts or the distal phalanges. This is the second feature. Resorption or erosions of the tufts or the distal phalanges. There is evidence of resorption of the tufts or the distal phalanges of most of the fingers. There is evidence of resorption of the tufts or the distal phalanges of most of the fingers bilaterally, indicating this is called acroosteolysis. Acroosteolysis, as you can see here, this is the proximal phalanx, middle phalanx, distal phalanx. The distal phalanx here is resorbed. Proximal, middle, distal phalanx here is partly resorbed. Its tuft is resorbed. Tuft is resorbed. This bone, this is the proximal. Can you see the middle? The middle and distal phalanx is completely resorbed. Okay. So in this case, you can see the resorption of the tufts or the distal phalanges. This case, no, you can see. You can see this feature. You can see the resorption of the tufts. No evidence of tuft or distal phalangeal resorption. Okay. The last finding is the diffuse arthropathy or the generalized narrowing of the joint space. Okay. So here you can see the generalized narrowing of the joint space. Generalized narrowing of the joint space seen in this area and in this area, not in between. Okay, in between is normal. Look here, this is normal. This is a characteristic finding of arthropathy of scleroderma. Leave this part, it spares the metacarpophalangeal joint, okay, and take the periphery. And here. Leave here and take here. So it takes here and here. Okay, mainly involving the proximal and distal interphalangeal joints. Sorry. Proximal and distal interphalangeal joints, as well as the radiocarpal joint. Okay, let's see in the other case. Yeah. The distribution of the arthropathy or the joint space narrowing involves the distal and the proximal and distal interphalangeal joints, as well as the radiocarpal joint, and disperse the joint between. Okay, this is what to expect to see on the musculoskeletal case of scleroderma. So if you got a long case with multiple systemic findings of scleroderma, how to comment? You will say like this. The findings indicate a multi-system disease with involvement of the respiratory system. So the first thing is with involvement of the respiratory system, manifesting as an interstitial lung disease with either a usual interstitial or non-specific interstitial pneumonia pattern in both lungs. Number 2, involvement of the gastrointestinal system, manifesting as esophageal fibrosis and achalasia. Number 3, and involvement of the musculoskeletal system with bony erosions, arthropathy, and soft tissue calcinosis. So the findings indicate a multi-systemic disease involving multiple systems. The principal diagnosis, systemic sclerosis or scleroderma. The principal diagnosis is systemic sclerosis or scleroderma, the differential diagnosis. Okay. The differential diagnosis of the interstitial lung disease is either non-specific interstitial pneumonia. What is the difference between the non-specific interstitial pneumonia, the usual interstitial pneumonia, the idiopathic pulmonary fibrosis? I've mentioned them previously. Non-specific interstitial pneumonias, opacities due to underlying connective tissue disease as rheumatoid arthritis and scleroderma. Usual interstitial pneumonia, significant fibrosis due to underlying connective tissue disease. Idiopathic pulmonary fibrosis, significant fibrosis, which is idiopathic. Drug-induced interstitial lung disease or amiodarone lung fibrosis, and asbestosis. Differential diagnosis of acrosteolysis. It's very important. The first one to come is scleroderma, then hyperparathyroidism, then the psoriasis and the Raynaud's, then the trauma and frostbite. Again, scleroderma and the hyperparathyroidism, then psoriasis and Raynaud's, then trauma and frostbite. The differential diagnosis of soft tissue calcinosis is scleroderma and the hyperparathyroidism. So the management here notify the referring physician and recommend rheumatology. recommended discussion at rheumatology MDT regarding further management. So this is the end, and thank you.